Thank you. Well, I'd like to welcome everyone to the Grey Bruce Public Health Meeting for Tuesday, January the 31st, 2023. This obviously is our first meeting for 2023. So we'll now go to item number 1, which is a call to order and the roll call. Kaylee, could you do the roll call, please?
I can. Chair Bartlett.
Present.
Vice Chair Milne.
Present.
Sue Patterson.
Present.
Helen Claire Tingling.
Morning, everyone.
Ian Body.
Present.
Kenneth Craig.
Here.
Luke Charbonneau.
Here.
Chris Peabody.
Present.
And Nick Saunders.
Nick's there, just I think he's on mute still.
We can't hear you, Nick.
Can you hear us? If you can just nod your head, Nick, if you can hear us. Okay. All right. We'll continue on and see what technical part we can get Nick so that he can speak.
I could hear him a few minutes ago.
Oh, is that right? Okay. Okay, are there any amendments to the agenda? Seeing none. Approval of the agenda. Could I have a mover to approve the agenda? I moved by Ken Craig, seconded by Warden Peabody. Any further discussion then on the approval of the agenda? All in favor? That's carried. Any disclosure of pecuniary interest from anyone? Seeing none, we get down to the adoption of the minutes for Friday, December 16th. Can I have a mover to adopt those minutes? Moved by Sue Patterson, second by Brian Milne. Any further discussion on those minutes from December 16th? Mr. Craig.
Thank you, Chair. Just a couple of comments. Page 2 of 5, it's the election of the officers, and it was recorded that the vote by ballot was conducted, and it says Alan Barfoot was voted acclaim as and it's just the wording. You can't be, it's one or the other. You can't be voted and acclaimed. It's just one of those things.
Yep. To be honest, I didn't notice that. Kaylee, can we make that amendment then?
Of course.
Okay.
And also, if I may, Chair,
sure.
It's more of a procedural question that you might be able to answer for me. 10.0, the in-camera session, had the session, and then 11.0, the meeting adjourned, but you can't adjourn a public meeting of a closed session. And I'm not sure. Maybe just didn't write it down or whatever. So it's just to be aware of that. I'm not sure how you'd like to proceed with that, Alan, but just to notice.
Yeah. Okay. No, those are notes are duly noted. Thank you. Okay.
Chair?
Luke? Yep, go ahead.
I just asked, was there a resolution? I just can't recall. Was there a resolution to rise and close prior to adjournment? Because if there was, it shouldn't be in the minutes.
Yeah, well, that's
the issue. I just asked you. We don't want to let it go. There must have been. Was there a resolution?
There must have been. I'd have to go back to confirm.
If there's a missing resolution, Mr. Chair, we probably shouldn't pass the minutes, or at least we should get clarity before we pass the minutes. So passing the minutes with a missing resolution, I think, would be a bad idea, Mr. Chair.
Okay. So the second point, I was just finding it hard to hear Luke from my standpoint here. I was just trying to get clarity on what the second point then was, though that was regarding the wording for the in-camera or the wording of the regular minutes.
Sorry, Mr. Chair, maybe I'm probably speaking in the wrong direction away from the mic. Can you hear me now, okay?
Yep, that's better, Luke. Yep.
Yeah, so I was just saying, as Ken pointed out, there must be a missing resolution in the minutes between items 10 and 11. And if there is a missing resolution, we probably shouldn't pass the minutes with a missing resolution.
Okay.
So perhaps we should defer these minutes or leave them until later in the meeting until they can be corrected and look to staff to see what can be done, but I just am reticent to vote to pass them if they're missing a resolution.
Okay, yeah, to be honest, I can't pull them up and look at that and this at the same time. So is it okay with the board? We'll just not pass those minutes for now then until we can research and see if there was a missed resolution there. Okay with that? Helen Claire?
Yes, thank you. Absolutely concur. I'm reasonably sure that a resolution occurred, but I don't have it in my notes. And since we're not passing the minutes right now, I offer up that the correspondence as listed 6.2, 62.1 and 62.2 includes the honorifics of the MPPs Jones and Fullerton, but it doesn't include their titles and should. The minutes should reflect that they are members of provincial parliament and not just simply their honours. So I request that the minutes be corrected to fully to show their positions. Thank you.
Okay. I'm sure you made a note of that, Kaylee.
I did.
Yep. Okay. Thank you. Okay, so we're okay then to move down to put those adoption of the minutes on hold then for now, and we'll come back to them. So we're down then to correspondence and news releases. First one is then under correspondence 6.1 and 6.1.1, the resolution from Sudbury. Do you want to speak to it, Dr. Era?
Certainly. Thank you, Mr. Chair. The Public Health Sudbury District carried a resolution related to encouraging school boards, sport and recreation organizations and early learning centers to improve physical activity levels. And this is related to stats that compares the level of activity before the pandemic, during the pandemic, and after. And the recommendation is to endorse. It could be very well received as well, since we're already, my recommendation is to endorse, although it couldn't be received. We as a health unit take physical activity as part of our mandate, and there are many programs that promote physical activity. It's related directly and indirectly to the opioid crisis as well as a prevention measure. So there's a lot of work happening about it. Nevertheless, for the support of other health units and their endeavor and the mission for the province, endorsement can be appropriate.
Okay, well, I'll look for the board direction. Do I have a mover then that wants to endorse this resolution then, or a motion to receive, whichever comes forward? Warden Milne?
I'll move to endorse.
Okay, do I have a seconder then to endorse?
Let's see.
Councillor Body has his hand up.
Okay, sorry. Yeah, I can't, on my screen here, I can't see everyone on there. So yeah, just holler out then. Okay, second by Councillor Body. Any further discussion then on that motion? Councillor Craig?
If I may, please, Chair, what's the difference between endorsing and receiving? You'll have to excuse my steep learning curve, so.
Yeah.
Dr. Certainly, through you, Mr. Chair. So there is limited political capital to be spent and limited resources. So it is best practice for the board to tailor both towards issues that are critical or issues that are there is an added net benefit in comparing to the other. Sometimes the practice historically in the health unit over the past 10 years, I looked at previous minutes, is to endorse anything that is supportive to public health mission for the first time, then receive it down the road if it repeats. So in this case, it's the first time we see a resolution related to physical activity, specifically after the pandemic. So endorsement will support that board if they wanted to ask for more resources from the province, for example, or if they wanted to basically be an advocate for their area or for the province. And they're not mutually exclusive. So when we endorse, that means we're going to send communication correspondence to the ministry to say we're supportive of this, and it adds to their efforts in that area.
Next question, Mr. Chair.
Luke? Yeah, Luke?
Thank you, Mr. Chair, and I just to follow up on that. So, Doctor, has there been some correspondence or some communication between yourself and the local school boards on this? The way this is written, it looks, the school boards know that the students need physical education, right? And it's a little bit, I don't know what the right word is, maybe a little heavy-handed or a little bit, could come across as us saying, you guys should promote more. Here's the health unit saying you guys aren't doing enough, right? And I just wondered, will they take it when they receive this as support for their mission and not us sticking their nose in their business?
Through you, Mr. Chair, the correspondence will go to the other health units, to the ministry, not to the local boards. The issue is identified in Sudbury. So if this is going to entail us communicating with our schools, it definitely will be proactive and in a way that it's going to support their mission. Rather, it's a one-sided telling them what they need to do.
Sure, and through you, Mr. Chair, I just did a quick follow-up. If this were to be picked up in local media, though, it would be taken as the Board of Health encourages or suggests that school boards should do more to increase physical activity, to improve physical activity level among children and youth. Like that, it'll be reported in the local media as us giving that encouragement to them. So I just, as long as there's a good sense that you have that when they hear that in the media, that they'll receive it positively. That's all. Because we should be working together rather than trying to torque it in some way.
Certainly, through you, Mr. Chair, again, this communication would be to the ministry, to the provincial level, and it is about the Sudbury district area. And if there is any media communication from us, or usually the practice from media outlets to reach out to us to get our perspective, we are supporting another health unit and their mission. That definitely it would not be from us to our school boards. The issue is not identified in our area to start with. But I understand the sensitivity and if it is to come to communication locally, it will be done definitely with complete carefulness.
Okay, does that help clarify, Ken, your points and yours as well, Luke?
Yeah.
Yes, it does.
Thank you.
Okay, thank you. Okay, so then I'm trying to remember now, did we vote on endorsing on that resolution? Kaylee, did we have the vote on that?
No.
Okay, so we'll call the vote then on endorsing. We had a mover and seconder for the correspondence and from Sudbury. All in favor? That's carried. Next, then we'll move on to media releases, Dr. Era, or is Denis going to join in?
Hello.
Hi, Denis.
Hi. Through you, Mr. Chair, there are 5 media releases on today's agenda. The first 2 were issued December 19th. One announces the appointment of Mr. Alan Barfoot as Board of Health Chair for 2023. while the other officially launched Grey Bruce Public Health's new logo and brand identity. Public Health issued a news release January 3rd to announce the sunsetting of the Grey Bruce COVID-19 Vaccine Task Force, which launched early in 2021. And a media release was issued January 10th to inform the public that Grey Bruce Public Health's VPD nurses will be returning to area secondary schools in February and March to hold in-school vaccine clinics for routine publicly funded immunizations. In-school vaccine clinics for elementary schools are set to resume in April and run until early June. And finally, on January 17th, Public Health issued a media release to coincide with National Non-Smoking Week in Canada. The release highlighted ways local residents can access cessation supports and resources. And that concludes media releases.
Thanks, Denis. Any questions for Denis? Seeing none, don't hearing any. Could I have a mover then to receive the media releases? Moved by Helen Claire, seconder.
Just say your name.
Ken Craig. Yep. Okay, all in favor? That's carried. Next is number 7, the MOH update. Dr. Era.
Thank you, Mr. Chair.
Yeah, they find you anywhere, can't they?
Yeah.
She can plug it from the back. Sorry, Mr. Chair, some technology issue. So the update, Mr. Chair, the first part of the MOH update is related to the COVID situation. The COVID-19 activity has been slowing locally and remains relatively low and stable after a relatively small uptick late December, early January. Just in terms of numbers, a proxy that we've been using is the number of new cases per day, and it is recorded in the high risk sector, but it's a proxy of the transmission. Currently, it is around 5 new cases per day on average, and early in January, late December, it was around 10 per day. And that is in comparison to October, when it peaked in the fall, it was around 30 new cases per day. So again, we are in relatively slow and stable period. The hospitalization is another indicator. Currently is 2 COVID cases in the hospital, which is very low. COVID outbreak activities, 3 active outbreaks in long-term care. So all in all, it is a very favorable position. With your permission, I'll share a slide from the data provincially and locally.
Sure.
So this is the scorecard provincially. It was reported January 11th, a few weeks ago, and it shows the data from the previous 2 weeks to it, so around the New Year's. And you can see throughout the jurisdiction, Ontario is relatively low worldwide. I'm gonna jump to the health units breakdown. And the light blue or the blue is increasing activity, green is decreasing. Grey Bruce is close to the lowest. The difference between these health units is not very significant. We're talking 20 cases per 100,000 versus 50. Again, these numbers actually decreased in Grey Bruce relatively as well since. The map for hotspots for Southern Ontario and Eastern Ontario would show that maybe Owen Sound has a bit more activity than the rest of Grey Bruce, but relatively we are on the lower end of transmission. The map, I pointed this out and it still stands even in the very remote areas of the province. There is higher transmission. So some people referenced the activity as correlated with the remoteness, which is not accurate. it can be, there could be discrepancies there like the way it is right now. We are remote, Northern Ontario is further more remote, and there is more activity there. And the map for test positivity would show that during the holidays, there was some lighter color, which indicates higher positivity. But again, it's a very low end, and it is in the age group between 18 and 60 mainly. But again, it's not of very concern. And I suspect when we receive the next set of data, it will be even less activity. So that's the update on this front. Mr. Chair, happy to take questions.
Okay, any questions for Dr. there? Ken, do you have a question?
I do, thank you, through your chair, and I'll have to call on you to let me know whether this is an appropriate question or not. You can choose. Through you to Dr. Era, World Health Organization just made some decisions the other day regarding whether the COVID outbreak is still an emergency situation or not. And I'm wondering how that affects your ability or the way you communicate to Grey Bruce preventative measures by public health. Is an announcement by an international organization helpful, or does it hinder our message as we continue to deal with COVID effects?
Through you, Mr. Chair, in general, it would not affect our messaging locally in general, unless there is announcement related to a new variant that might change the parameters of the management. But the recent announcement is really not very relevant. We have, as you can see, in the jurisdiction in Ontario, lower activity, and in Grey Bruce even more lower. The messaging that I have put out to the public that staying up to date with vaccine remains the best protection for people to be careful, specifically if they have high risk conditions, immunity condition or comorbidities, heart, lung disease. If their family members have those conditions, it's warranted to be a bit more careful. But in general, for the public, the pandemic more or less is behind us. The emergency has been declared over since last spring, and the data from the fall, when the expected increase, has been reassuring that there has been an increase, but it is manageable without the need for extra resources, which is the definition of emergency.
Okay, thank you.
Okay, that answer your question, Ken?
It does.
Okay, thank you. Dr. Era, can you proceed on then with the rest of your update?
Certainly. For 7.2, the item remains standing, no update on it, Mr. Chair. For 7.3, I will, with your permission, I will hand it over to Dr. Zayed to provide that update.
Okay.
Through you, Mr. Chair, I will share my screen.
Okay.
So I'm going to provide some update today on the. Can you see? No. Can you see my screen? No.
Yep.
Yeah.
Okay, thank you. So for the new year, I'm going to give an update on the situation of the opioid and illicit drug use. The main items related to prevention, surveillance, emergency response, harm reduction, treatment, and the recent update for December and January. So for the prevention, there is ongoing progress related to the locally driven community project led by Grey Bruce Health Unit, or Grey Bruce Public Health at the provincial level, systematic review and literature censuses, and we conduct the survey for the 34 health units. We finally got the approval, the ethics approval, which was really tedious process from public health perspective. And then the ethics approval from Unity Research, which is the University of Toronto. So we have to have 2 ethics board approval to go through the research. So that was a delay and anticipated delay, but we start from today the pilot study. I will talk about that more. For the surveillance, so we have the surveillance, as you can see. This is the opioid-related deaths confirmed and probable, and this is from the coroner report. The suspected, the confirmed are the one in the dark color, and the suspect or probable are the other, the different color, the brown color. So you can see here, it is still like sometimes it's up or down, but there is no still a trend of lower trend that is consistent. Now we have more data by FSA or by area, which is really useful. So drug-related suspected death is 30 deaths by November 2022. And we have more data, which is as promised by the Chief Coroner Office. We have more data now that we get in areas. So this really will inform our intervention. Again, this area, this is again settings related to where the overdose or the fatal situation happened. So so this is by again by settings. So it's all informative data that we recently start to get on a weekly basis from the coroner's office. So as you can see, it's more in the private settings and other area like outdoors. So this is really very informative data. I am expecting that will be helping us more in our informed intervention. Again, this is the surveillance across Ontario for the year 2022, and you can see here Grey Bruce compared to other health units. This is the data that we started to have also. This is the syndromic data we received every day. So our data analysts every day go to check the emergency room data, which is called ACEs data. So we get data about opioid overdose every day. So we see that trend, and I will talk about that in the health report, health status report. But this is a different setting of things that are important to public health. So we get this report every day from emergency room. So the emergency, I'm talking specifically about the situation in Saugeen. So since August, we had 4 cases of suspected opioid-related death. The opioid was suspected to be contaminated with fentanyl, and again, fentanyl continued to be a problem. The illicit drug use at the local level, suspect opioid-related deaths prompted declaration of emergency. Historically, that's happened in December. Emergency required mobilization of multidisciplinary resources. Public health plays a role in offering expertise, in mobilizing effort based on expertise with community engagement, equity, and community needs assessment, program planning, evaluation, and monitoring. So we are not taking this emergency as a response for emergency, but it is an important opportunity to do a more framework for action as leveraging capacity, assess the need, the evaluation, and the equity. And we started to do like equity assessment tool to measure the equity situation, and also to mobilize the resources and leverage the capacity of the local community, which is the most important thing, to have local capacity. So that's something that we focus on with our partners in Sobein. For harm reduction, there is a promotion plan for widespread naloxone use, and that's an important piece for prevention of death, which is a direct response, working at the local level with partners on assessment of supervised consumption sites as something we need to also discuss and move along. A consolidated plan for shared needle program that we have. For the treatment, we are collaborating through outreach, and the outreach is really proved to be important part for treatment and accessing people who are unattached or do not have are non-boosted or have a issue with housing. So reaching these people is very important. Indicators, what public health is offering in terms of this outreach is the training, advocacy for certain issues. For example, if we find like human trafficking issues, we do this education. If there are indicators of success, so how do we know that this project is really performing well? So we provide the indicator for success. We work with the COMO group, which is a provincial working group on promotion of safer opioid supply. The update for December and January. So in December, from December 1 to end of December, we had 60 reports for suspect opioid overdose received. 94% of those overdoses were non-fatal. 6% was fatal, one case. 81% of suspected opioid overdose reported to Grey Bruce Public Health were male, and the overall median age was 39. There has been a mix of drugs used in overdose, including cocaine, crystal meth, fentanyl, and alcohol. When the drug was reported, 82% of the overdoses include fentanyl or suspected fentanyl. The preferred route of administration was inhalation. In January, we had, this is till January 24th, 4 reports for suspected opioid overdose. 3/4 of those overdoses were not fatal. And again, 25% of the doses were fatal. So one case happened till 24th of January. We are still awaiting confirmation if it is a suspected opioid overdose. There is also, again, it's more in males, and the median age was the age of 26. We always find between 25 to 40 is the most age of overdose. 3/4 of these overdoses were due to fentanyl use, and one of them where the route was not known. We had recently also, in addition to the one case, the fatal case, the person before the 24th, there was another fatal overdose on January 25th. For Sobein First Nation, I mentioned the things that we are doing now. We are participating with EMS, OPP, and Sobein First Nation Fire, and we are having this task force. In addition to that, we will also, with leveraging the capacity, we try to work with focus on prevention. So have more discussion with Sobein on healthy baby, healthy children, postnatal mothers, parenting. So we start to have this discussion with our partner there, and we will include also Niash Ring or Niwash community in this discussion moving forward. Other activity other than the task force, the provincial community of practice. There is also, yesterday was a roundtable discussion facilitated by Public Health Ontario, focusing on key lessons of community partners across Canada to learn from implementing supervised smoking inhalation rooms from Saskatchewan, as well as best practice for day-to-day operation. And there is a growing discussion on the harm reduction using smoking, the smoking as a harm reduction tool, and evidence-based literature in this area. So this is something that have some growing discussion and more evidence at this point. And as I mentioned, now we are starting the pilot survey for from today for 5 public health units. And we'll run the survey after the pilot study for the rest of the public health unit. And the aim is really to focus on prevention. The aim is to support evidence-based intervention for use across the board for effective prevention strategies to prevent or delay the use. And that's my update for today. Happy to answer any questions.
Thanks, Dr. Zaid. Any questions? That's a pretty action-packed report there. Warden Milne.
Thank you, Mr. Chair. Just a couple things. First, as you indicated there was a ton of information there. And, you know, I'm not trying to be critical, but it would have been really nice to have that ahead of time to have, you know, look at it a little more. My question is if we could go back to the map of Grey Bruce that showed the number of overdoses, I believe it was. What are the metrics around the areas that were delineated on that map? It seemed to be very random, and it's hard, you know, I think in terms of lower tiers, you know, those lines, it didn't appear to be anywhere near that type of line. I'm just wondering how that map was constructed, I guess.
Can you put it back? Mr. Chair, we're just putting the map up on the screen.
Thank you. Yep, that one there.
Yeah, so this is the drug-related death, the 30 deaths until November. And this is the result that we get from the coroner's office. And this is, as you can see here, the legend. There is from 1 to 1.2, the white areas, and there is.
So can you make it bigger? Thank you.
So this is the area where we can see here the 10.2 to 13 is the highest area, and this is more of really it looks like it's all over the place, as you rightly mentioned, and there are areas with low 1 or 1.2 or less. So again, maybe that's not informative right now. This is a continuous report. So this is not informative as it seems, but over the time, I think the continuity of these reports can help us to have some more decisions. In addition, as it seems right now that it's all over the place, we can also investigate what kind of things, like, for example, if you localize the effort in Owen Sound, as we were thinking that there's a high percentage is Owen Sound, maybe that from an equity perspective will not be the case, because if the death happens all over So it's not the case. So we, from an equity perspective, this can be in consideration after after we thoroughly study these maps. So the good things that just I want to share this kind of data today. I know there are plenty of data, but I mean, we haven't had all this data before, and we always have a gap in data about opioid. So these kind of information right now are available and on a consistent basis, and that's good for us to follow up. But yeah, I will provide this information early before the report if I will do that.
Thank you.
Mr. Chair, if I can build
Yep,
add
go
to
ahead.
Zaid's question. So there is a saying in epidemiology about graphs. It goes something like this: all graphs are inaccurate, but some of them are useful. And this is on the way it stands, might not be accurate. This is data based on postal code, and postal code in Grey Bruce is different from postal code in cities where one block is one postal code. Here, postal code can stretch through two municipalities or the border in between. But like Dr. Zaid said, the change in the map over time will be helpful. So if we look at the area that is white around Meaford, for example, if we see this is getting darker as we go in the year, we will factor in that there is increase in the incidence of death in that area, and we can respond accordingly. If we deploy resources to different parts of Grey Bruce, this will help us as a start point and the baseline to compare to. And one final point, that it comes into play, and it comes into play in different ways. Grey Bruce has a lot of travel. People travel half an hour for almost anything. So again, those borders might not mean what they mean, depending on the activity and where people might be exposed to purchasing drugs or using drugs, or might not be the same postal code where the person's address is when they passed away. Anyways, it is a useful set of data, especially in the long term, like Dr. Zaid said.
Thank you very much.
That answers your question, Warden Milne. Okay.
Yes, it does. Very well.
Okay.
Thank you.
Okay, other questions? Sue?
Yes, thank you, Mr. Chair. A little off topic, but still relevant. I'm wondering if Dr. Zaid or Dr. Era would comment, and I know it's initial, but maybe there's work going on behind the scenes. As of today in BC, it is no longer a criminal offense to possess small amounts of illicit drugs. Has the Ontario Working Group been involved with this, or is it still very initial for Ontario?
Through you, Mr. Chair, this is a great question. Actually, one of the, as you know, we have this working group from HOMO, and one of the priorities is the decriminalization. So this is not an easy thing. So we are working, like we have to have the evidence. We have to have, like, there are controversial, especially these controversial issues. So if BC is announcing something like that, it will help or inform other provinces, and it is a collaboration. And as yesterday, for example, we had this is smoking harm reduction initiative that happened in Saskatchewan, and how it reduced the death from overdose. We can also have this initiative to help the decriminalization discussion here. So this is one of the priorities of the working group working on.
Very good. Thank you.
Okay, other questions? Helen Claire.
Thank you, Mr. Chair. Through you, just wondering if the working group raised the need to reinvigorate the Ontario Opioid Emergency Task Force at the roundtable. Thank you.
Through you, Mr. Chair, again, this is one of the work that we are doing. It is one of the priority. We have sent letters similar to the Board of Health here to the federal department and the provincial. We haven't heard yet about that, but there is a lot of effort in collaboration provincially on the emergency through our work group.
And answer your question, Helen Claire, go ahead.
Just to follow up, Mr. Chair, if I may respectfully request that in the same way that every single month, pretty much I come here and sing this same song, I respectfully request also that it be raised at every single opportunity. I'm very aware of the number of letters that have been sent and the endorsements, and that's the very reason that I will keep requesting that we try with every single ounce of power that we have to move this forward so it get addressed. Thank you, Mr. Chair. Thank you.
Okay. Other questions? Nick?
Thank you, Mr. Chair. I also sound off the Helen Clary's message there. Just last night, I was watching the news on CTV, and there was a lady that was on there from Vancouver area who was going on about safe injection sites and the safe drug handling and stuff that's coming in the mail parcels and stuff. And we're starting to see that even in our own community up here in Neoshingaming and other communities that are surrounding us. If this isn't going to help the matters that are going forward with this opioid crisis, this is going to make things worse. Until mental health and until we can get the proper letters and the proper support and structure in place, I think we are going to continue to have this opioid crisis, and we need to come together collectively. And if that means asking the First Nations for letters of support to help move this forward and go up through ISC and other channels, then maybe that's what we need to do. We need to look at this as a holistic approach and not just through the lens of Western science. Thank you.
Thanks, Nick. I'm assuming, okay, I'll go to Dr. Era first.
Thank you, Mr. Chair. Just to add to Dr. Zayed's update, and it's related to the last two comments. In the last meeting, the board directed staff to draft letters and communicate with the First Nation community to co-sign. We proceeded with this, and yesterday we received the confirmation that the co-signing will take place. Not last night or this morning, I saw that email. So we will be circulating the final draft to the board before it goes to the ministry and the local partners into communication like the board directed us.
Okay. Just assuming that some of you certainly were at Roma and just reading articles. Warden Peabody, I think you had some meetings. I just wondered if you wanted to give an update maybe on your participation, where things ended up there.
Yes, I was able to meet with the Ministry of Health, with Minister Tibollo, the Minister of Mental Addictions and Mental Health, and the Deputy Minister of Health, Dr. Zahn. And I outlined the gaps that we're seeing in Grey Bruce with the treatment for mental health issues and the consequent addictions that we're seeing on all of our main streets. And very impressed with Minister Tibollo. He's very engaged in the file and very knowledgeable. And he asked some good questions about distances that people had to travel in Bruce County for treatment. So I thought he was very engaged minister. And then Dr. Zahn is also very interested in the whole issue of access in rural areas. They did fall back on the treatment center that's going to go in Sound. That was their big thing that they promoted. And Minister Tibollo was quite excited about coming up here for the ribbon cutting of the center. But he says it's opening in April. I'm not sure the timeline of that. I don't know if he was realistic about that. The point is, I think they're very engaged in this, the people in the ministry. And I had some good discussions.
Okay, thanks for that update. Dr. Zayed, you had your hand up there. You wanted to comment?
Just I want to comment on Nick's points about the Western literature. We have really an open dialogue right now with our counterpart in Stogin and Newash about promoting the healing centers and the lodge and other like involving elders in role modeling and working with indigenous culture to help the youth and the young people in the community to adopt this healing or model, the indigenous model of healing, which is really helpful and have been very helpful actually in the prairies before to have this camping in summer for example, urban indigenous young people to come to this camp and have this sense of belonging. It really helped to have these cultural continuity initiatives. Thank you.
Okay, Warden Peabody.
Sorry, Chair, I forgot so the main ask I had was that the ministry fund the mental health, the MHART program with the police, where they put the social worker, mental health nurse with the OPP or the local police, and that there'd be a dedicated funding envelope for all municipalities for that. And although it was a positive discussion, I didn't get any indication they were willing to fund that full time. And I think where this program has been in place, it's an excellent program in dealing with apprehensions by the police under the Mental Health Act. And I think we all do need to push for the full-time funding of that program with our police forces. Didn't get a yes or didn't get a no. But we should all push for a yes on that.
Okay, thank you for that. Any other questions or comments towards Dr. Zayed's presentation? Just gonna flip and see if no, nothing from Ian. Okay, so seeing nothing from anyone else, we have a mover and seconder to accept Dr. Zayed's report. Moved by Luke Charbonneau, seconded by Ken Craig. Any further discussion then on her presentation? All in favor then to receive that? That's carried. Kaylee, if you can help me, I wrote out, I didn't have a chance to print off the agenda, so I just had marked onto there. I'm guessing maybe Kim's next on the agenda, but I'm not sure. You can just help me on that.
Correct, Chair. Perfect services now.
Perfect. Okay, Kim?
Okay, through you, Mr. Chair, this is the auditor appointment. So we're looking for the board to appoint BDO Canada as our external auditors for the 2022, 23, and 24 audit years. We did take our audit services to tender this year, so we went through a formal RFP process. We only received 2 bids back. We scored them on experience, personnel, the product quality, the references, customer service, and their fees. And BDO was the successful proponent of that RFP. So we're looking to formalize that contract with them with the board approval.
Okay, any questions on that? Okay, see, should have a mover. Sure. Yeah.
I had a question. Unless do you want the mover and seconder first, or do you want the question?
I'll do the mover and seconder first, and then have on that. So you're prepared to move the motion?
Nope.
Nope. Okay. Have a mover to go on the recommendation then of hiring through the RFP that was done to hire BDO for the upcoming 3 years and on the audit. Could I have a mover? Ken Craig, the seconder, just to get it on the floor. Luke Charbonneau. Warden Milne, you have a question regarding that. We have a mover and seconder on that motion.
I do. 2 questions. The first one was, I presume the different metrics were weighted there. I'm wondering what the price, how it was weighted percentage wise in relation to the other metrics, and what was the difference in price between the 2 quotes? Thank you.
Okay, Kim?
Through you, Mr. Chair. So the price was, I think, 20 or 25% of the total proposal. There was a $10,000 price difference between the two firms that quoted. So price did end up playing a piece in the decision that we made.
So, Mr. Chair, if I might add, so I'm presuming from that the BDO quote was less. Is that what you're saying?
Yes, that's correct.
Thank you.
Okay, any other questions then regarding that motion? Just make sure Ian or Nick haven't got a question. No.
Helen Claire has a question.
I'm sorry.
Helen Claire has a question.
Oh, I'm sorry, Helen Claire, go ahead.
Thank you, Mr. Chair. Through you, I would find it useful if, as a board member, that we are being asked to endorse a choice, that we were given a presentation of all the criteria that went in that allows us to make informed decisions at the board level. Thank you. I'm not sure if that can just be done a full synopsis here on the fly prior to the vote being taken, or if this is just something that's useful going forward. But I personally would request that we consider that. Thank you.
Okay, I'm going to ask Dr. Era to comment on that. Obviously, you've got a format that you used for Kim's department to go through that. I wonder if that's one that was just established for this this time, or whether that's one that's been used in the past, Dr. Era.
Mr. Chair, if I can turn the question to Kim, she's the expert in the details about the criteria that was used.
Sure.
Yeah, through Mr. Chair. So through you, Mr. Chair, we follow the procurement process that we do for all of our formal proposals for market for consulting or any services over 50,000. The team develops what they think would be a fair scoring criteria. With RFPs, you don't want the price to be the main point, because then you might as well just go for request for quote. So we were looking for the qualifications of the audit team that was going to be proposed. We were looking for timelines that they could meet what the ministry was looking for. We were looking for references to see what other experience both firms or the proponents, what experience they had with government agencies, whether it's Board of Health, hospitals, municipalities. So we're looking for that, understanding of PSAB, the accounting standards that we use. So all those were factored into the scoring, and then of course the pricing fee were a component of that. So the two firms essentially ended up with a very similar score. One was scored a little bit higher by myself, and one was scored a little bit higher by the other person evaluating this. And then when it came down to the fee, the $10,000 difference for the services, that ended up being the deciding factor in this situation. So we only had the two proposals that we received that we went through that process on.
Okay, thanks. Helen Claire, does that answer your question then on how that was reached then?
Perhaps I wasn't clear. One of our principal jobs as the board is to superintend. And I just don't see how we can superintend, how we're being asked to vote on something when we're not given not just what the criteria were used, but how the scoring was. So I understand everything that was just presented to us, but we're basically being asked to vote on something that we weren't privy to it. So I don't want to make too big of a deal here. It's two different. It's a choice between two, but this is our responsibility. And whenever I vote on something, and I'm sure I'm not alone, I'm part of a highly competent board here. When we vote on something, I think it behooves us to know the details of how decisions were made that we are being asked to endorse. Thank you.
Okay. Any other questions or comments regarding that?
Luke Charbonneau has a comment.
Yep.
Yeah, thank you, Mr. Chair. I just, in response to that, the comments, my conception at least is that our role as the board is not to do the evaluation ourselves or to review requests for proposal and assess what the scoring criteria is called. Our role is to ensure that a criteria is in place, that we employ professionals to carry out the evaluations. So we have a scoring criteria that was used. It's a consistent one. It's one that meets an industry standard. We had professionals carry out that review, and they came to us with a recommendation based on the review. I think that that's our role, to ensure that we have those processes in place and that, we're doing this in the right way. So I think this procurement's been quite clear to me. This procurement's been carried out appropriately. We've got a result that makes sense, and we should proceed with it. Thank you, Mr. Chair.
Okay. Any other questions then before I call the vote then on the motion that was before us?
Mr.
Seeing
Chair.
nothing? Yep, Dr. Era.
Thank you. If you wish, we can provide all the details of the process itself in a separate communication, and we can have a vote after the board receives all that information. I'm looking at Kim, and I know there is a timeline for us to approve for an auditor to complete their work before a certain time, but if the need be, we can do that by email and call for an earlier meeting or for email process if possible.
Well, I mean, that what you've suggested is material that could be for like background, but I think Luke pointed out that, as far as we're concerned, the appropriate part has been done, and to Helen Claire's point, that seeing that report afterwards will give the background to it. But we have a motion on the floor, and I'm going to recommend that the motion go forward, and we'll see how the vote ends up from it then. So at this time, we'll call the vote on the motion that was presented to accept BDO then as the auditors. All in favor? Opposed? That's carried. Kim, you want to continue on with your presentation, please?
Yep. So for you, Mr. Chair, these are the November financials. So at the end of November, we had a surplus of just over $300,000. So this is the second consecutive monthly decrease in the surplus. We utilized $600,000 in COVID extraordinary funding to fully cover our mandatory programs and all of our COVID costs year to date at the end of November. So the $300,000 surplus was made up of $200,000 in the senior dental program. So that dropped about 35% from the previous month, as we're starting to see the dental fees from the local dentists and dental clinics trickle in, as they start to see a lot of the clients on our wait list. And also some of the larger equipment purchases that we had made early in the year, they started to arrive. So we started to pay for those expenses. So that surplus decreased significantly, and in just kind of wrapping up December year end right now at the moment, that's dropped even further. So the team was able to utilize most of that surplus that's been sitting there all year. They did successfully use a good chunk of it before the end of the year. There was no real notable expenses in November. Most of the large expenses related to dental equipment for the Walkerton Clinic. So anything that we could get in-house before year end and use the dental operating funds for, we did that. So sterilizers, x-ray pieces, I don't know all the terminology for them, but anything that was significant that we could get in-house, we did so. And we also had some project consulting fees, management firm, Colliers, that we hired. We covered some of their time as well with our year-end budget. For the capital projects, the Walkerton project is still moving along. So we've got a RFQ for the prime consultant. So that would be the architect firm. So we have received responses back, and we're in the midst of finalizing a contract with who will be the architect for the job. And we also circulated a RFQ for a cost consultant, and we'll be awarding that as well. So the project is moving along well, and I think we're on target with our timelines.
Okay, any questions for Kim regarding her report? Oops, flip, make sure you see if Ian and Nick are there. Okay, not seeing anything from them. So can I have a mover and seconder then to receive Kim's report? Moved by Warden Milne, seconder, please.
Ian Body?
Ian Body. Okay, any further discussion then regarding the receiving of Kim's financial report? Call vote, all in favor? That's carried. Kaylee, if you can help me on the next item.
Yes, we're going into other.
Sorry, it's just the in-camera?
Sorry, it's other business. Dr.
Oh,
Zayed
sorry.
is sharing her health status report.
Okay. So, Dr. Era?
Yeah, through you, Mr. Chair, I would like to share present the health status report for today. Again,
Oh, sorry. Yeah. Yep.
I'm sorry.
Yep.
For more data. So the outline, I will present the Canadian Community Health Survey data as is the main data resource. I will also touch on further data related to other data sources that we had and the upcoming reporting in 2023. So this is for like the new year right now, and we are trying to have more what kind of data that we have. As you know, since COVID, we had the last data set that we get was in 2015 and 16, and the next data was 2018, 19, and 2020. So in the data in 2019 and 2020 was interrupted because of COVID. So the data collection was stopped, and with that they resumed the data collection in September. So it was the time of data collection was reduced from 3 months to 6 weeks. And so there was a lot of issues to get data. So hopefully we are now on recovery, and we are coming on to have more data that can help us. And the data and the knowledge is really power and help us to know how we can inform our decisions. Again, the first item of data is a Canadian Community Health Survey. And this is a nationally representative survey of the health of Canadians that enables decision-making at the regional provincial level, and it is conducted by Statistics Canada. So the type of, there are 4 sections in the Canadian Community Health Survey. This is a general about the general health, risk and protective factors, chronic conditions, contact with medical service or utilization of service. The other, so as I mentioned, we have 2019 and 2020 compared to 2015 report, so that's we can see the trend. Again, this Canadian Community Health Survey is a self-reported data, so it has its limitations. So this is a phone survey. People are reporting on the questions they were asked from their perspective. So it is subjective to certain bias sometimes. The comparison, and it shows here some data related to comparison of Grey Bruce to Ontario and Canada, where we are at the province, in terms of province and in terms of the national levels. The survey, there are 2 surveys. There are the youth survey from 12 to 17, and there is the survey for 18 plus, and it is cross-sectional. So it is not like they are taking they are taking one time of what's happening at the time of the collection of data, it's helping through the year that when we have the data from 2015, 2018, 2020, but at that time, when the data is collected, it's a cross-sectional data. Next, so the report on the general health. So as I mentioned, the community survey report on 4 sections. The first section in general health, which is a life satisfaction, how people are satisfied with their life, mood disorders, perceived health, perceived mental health, sense of community belonging. So these are the most important data. If we go to the graph, that's the next slide, we can have here, you can see the 2019-20 data for 12 years and older. For both sexes in Canada is 93.3, and for Grey Bruce 92.6. Over 12 reported they are satisfied or very satisfied, compared to 93.3 in Canada and 92.7 in Ontario. So this is one example, and I will have the full report, and this will be for public information. The next one, I just highlight again. This is highlights. It's not everything in the report, but the full report will be published. The chronic condition that I just selected, which has an importance from before, is arthritis, asthma, chronic obstructive pulmonary disease, type 2 diabetes, hypertension, and body mass index, and overweight and obesity. Next slide is about, for example, the arthritis. In Grey Bruce, for example, the number of arthritis in 2015 was 27.8%. In 2018, 25.7%. In 2020, and in 2020 was 25.7. It's higher than the Canadian indicator, which is 19.5, and the Ontario indicator 19.1. You can see also this arch, which is the confidence interval. If you want to read a graph, if the confidence interval is this arrow on vertical lines, if they are almost overlapping, so there is no significant difference. So there is no significant difference in that one compared to the Ontario and the Canadian parameters. For the next slide is about asthma. Asthma was 11 in 2015, and then 8 in 2018, 6.5 in 2020. So that shows a lower trend that is going lower, which is really great, compared to 8 in Ontario and 8.3 in Canada. And again, you see this vertical arrow, they are kind of the same, so it's not a significant difference in the Ontario and the Canadian level. For that one, the chronic obstructive pulmonary disease, actually, this one, we have COPD is 6.8 in 6.1 in Grey Bruce compared to 3.8 in Canada and 3.8 in Ontario. So this one is really significant because there is like almost double COPD or chronic obstructive pulmonary disease, and this we will see that had a relation also attributable to the smoking level, which we'll see in when I will talk about their behavior. The next one is about diabetes. The diabetes is around 8% in Grey Bruce compared to in Ontario 7.5. So there is not like it is mostly similar. It's still something that we need to work on. The blood pressure is 20.7 compared to 17.3 in Canada, 17.5 in Ontario. And then there is a body mass index. Again, it's in Grey Bruce, it's 21.9 compared to in Canada is 24, and in Ontario is 22. So almost similar to the national and the provincial level. Moving to another parameter, which is the risk factors and protective factors. If we talk about smoking, alcohol consumption, and influenza vaccine, has selected 3 indicators. So for smoking, we can find here that in Grey Bruce, we have 19.2% compared to 11.2 in Canada and 8.9 in Ontario. So really, this is, if we talked before about chronic obstructive pulmonary disease as a complication of smoking, so we can see here the smoking is something that is significant here, and there is a lot of work, and this is one of our strategic direction, and a lot of work is done or is underway right now in 2023 or in our strategic plan for the first 3 years for 2022 to 2024 to work on vaping, tobacco, and smoking. For the next slide is about the drinking. So it's in Canada, it's again in Grey Bruce is 20.3 compared to 17.5 in Canada, 15.6 in Ontario. This is one of the of our also focus for this year, as we have the alcohol working group. We'll have more focus on community work and the community engagement specifically for the policies of related to alcohol drinking, heavy drinking. For influenza immunization, our level is 34.9 compared to 32.4 in Canada and 39.5 in Ontario. I think that this is by the time this statistics came, if I am really interested to see the 2022 data, and our VPD vaccine preventable disease program is working really independently to try to get the data locally, because I think the data will be higher with the COVID pandemic. This really encouraged more people, especially the senior, to have this vaccine. Talking about the last point or parameter is the contact with medical services. So again, the data here, if we go to regular healthcare, the graph shows that 90% have a healthcare provider compared to 90.6 in Ontario and 85.6 in Canada. I'm interested again that to see this number is slowly increasing in Canada, but gradually actually decreasing in Grey Bruce. And again, as I mentioned, these statistics are for 2019 and 2020, and I'm interested to see the number right now with retirement of some primary care doctors. And this is an important parameter, the utilization of health services. Also, our vaccine preventable disease program is doing a lot of work right now on documentation of vaccine from primary care provider, and there is a very good project underway. The other important thing is there is a data from Information Canada Evaluation Center surveillance, ICES, and it shows the data for pediatric, which I think is really a serious one in COVID, and I will report on that during COVID, the pediatric access to service, and also the specialist access to service has been really reduced during the COVID pandemic. And this is another organization that did this research. And this is a very good and strong research based on weighted evidence. So it's not self-reported. So it's more of a good investigation and solid investigation. Other data sources that I just want to highlight on, the opioid and illicit drug use, mortality and morbidity data. And as you see, we have now more sets of data that will help us. As this was a gap in before, so the data that we have at the local and provincial level will be very helpful. I mentioned the syndromic surveillance or ACEs, the data that we get every day for overdose, fall, and respiratory symptoms. And there is also data about the vaping and the rapid risk factor surveillance system. So if we go, for example, as an example for that, this is a local, if you go to the graph, this is some study done by our chronic disease injury prevention as one of the human health development matrix study that we are doing right now is focusing on the falls across lifespan and specifically for seniors. So we are trying now to compare falls pre-pandemic and during the pandemic and across the age and giving us more insight about the preventive measures. The next slide shows, as I mentioned, that this is the syndromic surveillance that we receive every day. So as I mentioned, the data analyst look at these sets of data and send this daily email, and this shows us the emergency rooms across Grey Bruce in terms of falls, non-specific infections, respiratory infection, fever, myalgia, and flu-like symptoms, injury, and gastro symptoms. So this is really a very good indicator, like on the spot every day that we get. The root or rapid risk factor surveillance system, and this year was not really rapid at all. It was delayed a lot, and we got this data. We got it now, and so it really like feels its advantage of having this rapid data. But at least we got the first cycle now, so we will have 3 cycles. Every cycle is 4 months, and the first cycle we selected these modules. So we selected the first module about COVID-19 information and how people how that impacts the population. And also about how they perceive information coming from health unit and other healthcare providers, like primary care or other service. So it was a kind of like delay, but again, hopefully it will be informative to us. The second cycle will be about opioid, and the third cycle will be about injuries and motor vehicle accidents. So for that one, the limitation, again, it only includes responses from people who own a phone and pick up the phone. There is also a representative bias. So, for example, it's not proportional to the actual population of Grey Bruce. Age 64 and below were underrepresented, and 65 above are overrepresented or overreported. Smaller sample size this year, potential bias, as we cannot be confident that the respondents' answers are representative for the population. But it gives us some sort of qualitative data, how like some sort of information. And as I mentioned, the information that we got this year is about insight on this cycle on COVID-19 impacts on finances and personal perceptions and feelings, utilization of services. The upcoming data, we have really we worked very hard on this set of data, which is the annual health report. So I'm really pleased to share that our communications team finalizing a work on Grey Bruce Public Health, this public-facing annual report for the period from covering 2020 to 2022. As you are aware, public health had to pivot in early 2020 to focus on its response to the COVID-19 emergency. And as a result, we had to put on hold non-essential tasks, such as developing an annual report. So this report will target a detailed timeline, and it's really, it will be really a great report on timeline of COVID-19 pandemic from the start of 2020 to the end of 2022 with graphics of this timeline, and section on public health response, Grey Bruce public health response on COVID-19 emergency, including data to contact tracing, case management, and vaccine, and reports with update data on other information on each program in public health, from healthy baby, healthy children, to chronic disease and injury prevention, financial data on the order of organization, infographic and charts, and more. So this visually appealing comprehensive report will be available in March. It will be provided also to the Board of Health. And that's the end of my presentation. Thank you.
Okay, thanks, Dr. Zaid. Boy, that talk about information overload. There's a pile of graphs and information there, and it's interesting to, compare Grey Bruce to Ontario and Canada. So, yeah, interesting on the trends, and also what we're looking for in the upcoming years on reports. So that was a lot of detail and great information. Comments from board members? Helen Claire?
Thank you. Amazing. Lots of detail for sure. Young males are overrepresented in all the high-risk categories, whether it be smoking, drinking, drug use, as we've seen. I'm just wondering, in the public health programs, is there anything that targets this demographic, particularly targets males? The information that we just received, we know is underrepresenting young people. So I'm even more disturbed by the statistics that we've just seen. Thank you.
Okay, Dr. Zaid.
Through you, Mr. Chair, I just want to clarify the rapid risk surveillance system is underrepresenting young people, but the Canadian Community Health Survey, there is a good representation of all age groups. In addition to that, the human health development project that we are taking as a strategic direction for Grey Bruce is working on human health across lifespan. And one of these lifespan, we are actually focusing on men's health and the women's health. So there is a specific matrix management structure project geared toward men's health.
Mr. Chair.
Yep, Dr. Era.
I wonder if I can chime in on one of the slides, if we can put it with Dr. Zaid,
Sure.
The current smoker daily.
Okay. I shared the music clearly. 1 second, I put my slides.
Or let's share the slides, Mr. Chair. I can share it from here too. Let me share it from here and use my phone.
Can you see it now?
No.
Okay. Can you see it now? Okay.
No, I don't. I can share my.
Okay. Use it.
Code. So I can get them. Thank you. If you push this one. The people, thank you. Mr. Chair, just want to point out the data on, for example, the behavior. Trying to make it a bit bigger. Yeah. So just in follow up to Helen, there's a question. So the databases have certain limitations, and the cross picture from different databases will be will provide a better metric. Sorry, I'm just trying to get the mouse is really sensitive here. Will you be able to share it from my script? Sorry, Mr. Chair, we have some technology. Yep. Thank you. Just for the board's knowledge about reading those graphs, this is for example, the difference between smoking and drinking. There is significant difference between male and female in the Canada data. In Ontario, in Grey Bruce, like Dr. Zayed mentioned, the confidence intervals, these brackets overlap. So technically, we cannot say there is difference between male and female. And whenever you're looking at these graphs, the wider the interval is, means there is less certainty in the measurement. And the less certainty, although it's the same survey applied across Canada and this subset of it, it's related to the sample size. In Canada, we have millions of people or hundred thousands of people being tested, or the data comes from hundreds of thousands. So the confidence interval is very narrow. Here it is very wide, again, less certainty. And so long that this is, for example, female and male, they overlap, means we cannot say there is difference. On the Canadian level, they don't overlap, we can say there is significant difference. It's very similar to people around the table who know about the election poll. They will say this candidate is ahead of that candidate, but within margin of error. If there is overlap, there isn't much difference. So what Dr. Zayed emphasized here is the smoking. The smoking, you can tell there is difference between the margin of error, the brackets, between Grey Bruce and Canada, Grey Bruce and Ontario. And this is concerning. In the drinking, heavy drinking, there isn't difference. They overlap. So again, those sets of data help us direct our interventions and the priority of them. Just want to point it out, and in general, we can utilize this knowledge in reading any graph similar to this one.
Okay, thank you. Other comments, Luke? Luke Charbonneau?
Yeah, thank you, Chair. And so that's a good clarification, Dr. And I was looking in particular at Dr. Zayed raised it on the chart about COPD. And it seems to me that when you look at males in that chart, males in particular, there really is a true high level of COPD among males as compared to Ontario, as compared to Canada. And that's a serious concern. Dr. Zayed pointed out that COPD arises as a complication of smoking. So, to see these two things connected, I just wondered, do we have a sense, any sense at all of how this translates into deaths in our region? Like, I have to think that, COPD is a pretty serious illness, which has got to lead to a higher, so we must have a higher instance of death caused by COPD among men in Grey Bruce as compared to deaths at the Canadian or Ontario levels. Would that be reasonable to say? And do we have a sense of how much more serious that situation is?
Through you, Mr. Chairman, the COPD is a chronic disease, right, and debilitating disease. So we have maybe adjusted disability of quality of life is more than the normal population, like people who don't have it. So it's kind of it's affecting more the morbidity and disability rather than the death. But it is one of the 10 highest 10 causes of death across Canada, the COPD.
Seems to me, Mr. Chair, again, like of all the things, smoking and COPD of all the things that maybe require our most urgent attention in Grey Bruce are these.
And of course.
Are these items, and we just had a conversation about opioids, which is a serious problem and one that requires our attention. When we talk about an emergency response and wanting to, we even have a declared emergency in our region on that. I don't want to diminish that, because it is a serious issue. But this is the real, like, we're sort of the same as everybody else on opioids, right? Like Grey Bruce says we're no different than the rest of Ontario, the rest of the country on that. But here we have a unique and pressing problem on this front. And if in my mind, I don't know, perhaps Dr. Era or Dr. Zay can speak to it like this, where we are focusing urgent attention and the bulk of our resources really ought to be in this direction.
Yeah.
And perhaps some of these others are they're all important, but this is critical stuff right here for our region, specific to our region.
Through you, Mr. Chair, that's really a point like you did, a very important point. We are really doing a great work from a perspective of youth, vaping, and prevention and programs. There is a very important matrix that we are working on it right now, which include enforcement, prevention, and quitting, and harm reduction. So this is like the 4 pillars for tobacco, and starting from younger age, healthy baby health. So it includes healthy baby, healthy children, includes school health, and include chronic disease prevention. The communication and data analysts working together, as I mentioned, this matrix is one of our priority metrics right now, one of the most important one. And there is a lot of work that is underway as an immediate priority for our strategic plan.
Mr. Chair.
Dr. Era, yep.
Yeah, I would echo everything Dr. Zayed said, and I would invite the board to look at the issue from a slightly different angle. If we look at singular diseases and their burden on the society, whether it's death or resources or priority to other diseases, we would be looking at a healthcare lens. If we look at the public health lens, we know that the different conditions we're looking to improve are not independent from each other. If we improve the lifestyle of a person, less heavy drinking, less smoking, we're definitely helping them to reduce COPD. But at the same time, we are helping them to reduce their chances to go down road of substance use. We are helping them on the heart disease front, on the long-term well-being and preventing dementia front. So these conditions are not independent, and our work on one will affect other fronts as well. So again, if our mandate was to look after primary care or to look after healthcare, surgery in a hospital, we would use certain metrics like death, and we will see the change immediately. When we're looking at public health, we really need to look at different metrics and across different conditions. And that's why using sets of data like this one is quite useful.
Good. Luke, that answered your question. There was some good points you brought forward there, Luke, on direction for staff in the future from that report. Other comments and regarding Dr. Zayed's health status report? Dr. Zayed?
Through you, Mr. Chairman, I just want to also add to comment on what Dr. Harris mentioned. If you recall, there is a pyramid that I shared with you before, the Freedom Pyramid for population health. So there is the base of the pyramid is actually working or have an impact on the population, and the apex of the pyramid, which is individual or primary care delivery, is improving the health of individuals. So we are in public health more working to make the healthy behavior is a default, And these 5 tiered pyramids is really working on these 5 parameters to help the choice and helping improving the social determinants of health and facilitating the behavior, the healthy behavior to be the default for the population. So again, working on different behaviors can really improve the individual health problems.
Okay, any other comments from anyone? Sue Patterson.
Thanks, Mr. Chair. Dr. Zayed, a lot of good information there. Can you just go over how this data is collected? Again, I sort of missed that at the beginning. I'm thinking about falls, and is it just individuals who were contacted and not hospitals and long-term care homes where falls are reportable?
Through you, Mr. Chairman, this data about the falls are local data that we get from the hospital. So our staff, so it is not the same as a Canadian Community Health Survey. This is the data that we get from hospital reports. And this is an active, what is called active surveillance. It's not passive surveillance that we get as reports. It's our staff like actively looking for these data from the hospitals, and in the same time we get the data from syndromic surveillance. This is ER room that we get every day about the falls. So we get 2 sets of data: active surveillance, looking for this data from hospital reports and records, and syndromic surveillance, looking at sets of syndrome that comes from emergency rooms.
Very good. Thank you.
Okay, other questions or comments? Seeing nothing from anyone else. Can I have a mover and seconder then to receive Dr. Zayed's report regarding the health status report? Moved by Sue Patterson, seconded by, who hasn't done one yet? Luc Charbonneau. Any further discussion then on the receiving of that report? All in favor? That's carried. Kaylee, can you help me on the next item?
Yes, we're moving to public health matters, public health trial vaccine success. Dr. Era will speak to that.
Sure.
For you, Mr. Chair, the 2 items from Alpha are as follows. The first one is infographic on the success of vaccine campaigns across the province as a direct relationship or work from Health Units and Public Health Ontario. And it's a graph to highlight this success, whether it's related to the communication to the public or related to mass immunization and distribution. And that happened through different lenses that were used here. One of them is the data-driven activities. It's evidence-based distribution in general. There is utilization of the services, integrated services, where the vaccine was distributed through the healthcare system as well as public health, and through community outreach, and that's mostly through public health. The access was increased, and the final point there on the second graph is related to communication and amplified messaging. It's just a graph to highlight the success of public health, and it's and my bias is just one step of many that public health should put forward to highlight our work. Usually we are the victim of our own success because we do things very well, or when we do things very well, we avoid things that might hit the media. It's only when things go off the rail that the public will be aware of the importance of our work. So that's the first item. The second one is related to the winter symposium, and that on February 24, all board members are encouraged to attend. It's worth mentioning that the spring symposium, the annual general meeting, will be in person in Toronto. Open to questions, Mr. Chair.
Any questions from anyone? Okay, seeing nothing from anyone.
Helen
Okay.
Claire has a question.
Sorry, Helen Claire.
Thank you. Just wondering if the dates have been set yet for the spring symposium? Thank you.
Not to my knowledge. We can look into it further and send a date if it was confirmed.
You're talking about the one in June, Helen Claire?
I think that's probably a bit late for spring. I'm not sure when it is. I know we have one coming up in February. Yeah, I'm sure that it'll be circulated when the information is available. I was just checking I hadn't missed it. Thank you.
Yeah, okay. Okay, seeing nothing else on that. Thank you for that, Dr. Era. Next, Kaylee on the agenda.
In camera.
Okay, do you want to take 5 minutes before we go in camera? See nodding of heads. Okay, so my clock is showing that it's 11:47 there, so we'll take add 5 minutes to that. We'll be back in 5 minutes. How's that? Okay, I state that during our in-camera session, we only discussed items that were on the in-camera agenda, and that we have a further motion to bring forward. And if we had a mover and seconder on this motion or not, I can't remember. If not, moved by Ken and second by Luke. And can you read that motion then out, Kaylee, please?
Yes, that the Board of Health ratify the terms of the OPSU Protec agreement as provided in the report.
Any further discussion then on that motion? All in favor? That's carried. Seeing no other business then before the board at this time, we'll just look for a motion to adjourn by Warden Milne.
Brian Milne did have his hand raised.
Yeah, he was just making the motion, I think, Kelly. So our next meeting then is set for March the 3rd at 10 o'clock. And thank everyone for their participation today. That was a meeting that dealt with a lot of business. So thank you again, and motion
Mr.
to
Chair,
adjourn.
excuse me, I will second the motion to adjourn.
Okay, Helen Claire has seconded the motion. All in favor? That's carried.
Thank you,
Meeting
Mr. Chair.
adjourned.
Good
Thanks,
job.
everyone. Thanks, everyone.
Thank you.